Foster. I am a professor here at the Chicago School and a private practitioner in the Louisiana area, and I see a lot of trauma clients. Dr. Brown.
Yes, Dr. Andy Brown, based in the Carolinas. I practiced in North Carolina and in Florida. And I also work here at the Chicago School. And as an associate professor, I also treat trauma. I'm a traumatologist, and I train and certify traumatologist.
And do we have Dr. E yet? Okay, so we will get started, and when she pops in, we'll give her a chance to introduce herself. So today we're going to be talking about countertransference and the treatment of trauma. So let's get started. We'll have some other panelists come along. Again, I'm Dr. Susan Foster, Dr. Andy Brown, Dr. E will be with us shortly, and I don't know if Dr. Harris has made it on the call. Paging Dr. Harris. No, Jordan, I see you shaking your head no. So we're going to go ahead and get started. So Dr. Brown, you want to kick us off here?
Yeah, sure. When we deal with issues of transference and countertransference, really we're going back to Freudian times, and this is based in our earliest psychodynamic kind of constructs. It's reimagined a lot now with neuroscience. We have things like neuroception and parallel processing, which we'll certainly talk about today, which are, kind of offspring of the transference and countertransference. And here we see, the therapist and the client are continuously mutually influencing each other. And I would say that this is largely implicit. It can be explicit. In other words, this happens at an old brain level, sometimes without even knowing, which is part of the reasons some people come in to therapy. Obviously, they don't know why they have some of the triggers that they have. And we as therapists sometimes can bring those things out. And we as therapists, from a countertransference standpoint, can also be elicited too. We can have, we can most definitely and are continually impacted by our clients.
I mean, and when we think about burnout and vicarious trauma and some of those other phenomena that happen to us, it's easy when we kind of take the zoom out, zoom in lens just to see how impacted we really are. Jordan, can you monitor the participants and let us know when Dr. E gets here?
I'm here.
Wonderful.
I'm sorry, everyone. That was very strange. It said that it just didn't want me to be in here. So but I disagreed and I made my way.
Dr. E, do you want to introduce yourself really quickly, and that way we can?
Yes, absolutely. Sorry I'm late, everybody. I'm Dr. Christy Eldridge, and I'm one of the core faculty here in CMHC in the Counselor Ed department. And I also work in Denver with adult survivors of complex trauma. So things like adult survivors of childhood sexual abuse, human trafficking, organized abuse survivors, stuff like that.
So Dr. E, I'm going to pass the moderator baton back over to you.
Yes, thank you. Thank you all for starting this. You all were quick on your feet because since I had all the slides, that was good adaptation, which we need when we're working with complex trauma, that's for sure.
But just let me know when you want me to advance.
Yes, I came in just as you all were talking about this slide. So, I think one thing that maybe you've already mentioned with this is just the understanding that it's this ongoing dance that happens between therapist and client. So it's really not about how do I stay robotic and never have a reaction to my client. That's not possible. But understanding that our client's material really that's based on their actual feelings and thoughts towards someone in their life, usually in their past, that they put upon the therapist. That's the transference piece. And then for the countertransference piece, the therapist is going to have our own reactions to the client or to the client's story or material that brings up stuff from our own lives. And usually this stuff is our unresolved stuff. You know, sometimes we might be very aware of it and we can notice it when it comes up, but a lot of times it's the stuff we haven't dealt with yet that pops right up. And this piece, I'll talk about that if that's okay with the other panelists. These are three main responses, countertransference responses that we have when we're working with survivors of trauma. Maybe most obvious or most understandable is this instinct to want to rescue our clients. So when we're working with survivors, we might hear just the most painful, heart-wrenching stories of pain, of abuse, of survival. And it's natural as helpers at our hearts to want to make it all better for them. But in that, we can lose our boundaries. And that might be like, you know, let me give you extra time in a session, or even like, let's not talk about the hard stuff so I can rescue you from the painful emotions. But in trauma counseling, we have to talk about the hard stuff, or at least do some exposure to the hard stuff, even if we're not verbally talking about it. In the abuser role, this might be kind of shocking to hear, but it can feel like we're moving into an abuser role when we are pushing our clients to expose themselves to the really hard parts of their trauma. You know, counselors often tell our clients it might feel worse before it feels better. But when you're working with a client who's been through just unimaginable horrors, having them talk about it or remember it can feel like you're putting them back through the abuse. And it's very important that you're well trained for this so that you're not re-traumatizing your client, but you're doing appropriate levels of exposure. But even when you're doing that, it can feel pretty painful. It's also very important that we don't fall into an exploiter role as part of that abuser bubble. Sometimes clients that have unique stories, this happens with human trafficking survivors too much, is that they get put into this like token or poster child role, where for you, it might be very fascinating, actually clinically fascinating, to learn about these experiences that people go through, but that can move you towards exploiting the client for your own learning or your own interest. And certainly other people outside of the counseling relationship tend to do this too. Nonprofits who want a survivor to be their spokesperson, you know, things like that. So it's really important to be monitoring, making sure that whatever you're doing with the client is for the client's benefit and not for your own. And then the victim bubble, you're hearing the worst of the worst, you know, when working with these clients. So you might be feeling victimized by the content or the material that your clients are telling you, but you also might be feeling victimized by the relational dynamics between client and you as well. If you think about, especially with interpersonal traumas, our clients are raised, they're learned how to interact with people in this fluctuation of violence or threats of violence and seeming love. So this like back and forth, that is what a lot of people have been raised in, which all that material facilitates a kind of trauma bond, and that's all they know. And so that's what they're going to be bringing into the relationship with you. And so you might be feeling kind of jerked around or confused or disoriented when those dynamics are at play. And that can really lead to us feeling victimized, again, if we don't have our boundaries and our self-awareness intact.
A reaction when you're in the victim role, in the victim bubble, I should say, to use the parlance of Dr. E, is that there's a silencing effect that we sometimes utilize reactionary when we're reactionary to really gruesome, significant, impactful details from our clients. And the silencing effect can be just changing the subject, not allowing the client to sit in their discomfort. Sometimes for myself, telling myself, I have a humor defense. Sometimes I'll make light of a situation in order to break the tension and these kinds of things. So be aware that sometimes when we're in these responses, that we have reactions that can redirect or shut down our clients.
And I appreciated the word "we" there, Dr. Brown, because we recognize that we have found ourselves in each of these roles doing the work that we do. And I love the Venn diagram too, Dr. E, because there is the recognition that you can be in multiple states at one time with your clients. You know, Dr. Brown, as you talked about using humor, you know, as one of your victim bubble stances, I think about that in terms of that also I too suffer from the same defense mechanism there. And it also moves me right over into the rescuer role really, really quickly. And so I think the recognition that some of this happens at an intersection as opposed to a silo.
So from what Dr. Brown was mentioning, this like defense, naturally we have defenses. Anytime we have a perceived threat to our system, we're going to naturally respond with some kind of defense. So Dr. Brown was talking about humor as a defense. These are a few other main defenses that might show up for you. Denial, you might be in denial about our own reactions, like, oh, this doesn't bother me at all. I can handle this. I'm fine. Like, how many of us say that all the time? I'm fine. I don't need any help. Or even denial that we've made a mistake and not going to our supervisors or our colleagues to say, gosh, I really messed up. I need some help. With disbelief, this often comes with disbelieving the client's story. This couldn't possibly happen. This is too bizarre, or this is too horrific. Frankly, because the material can be just unbearable to hear. And then with judgment, this is almost, we think about defenses or defense mechanisms. Many of you might think of projection. That's one of our big defense mechanisms. Judgment is a form of that projection. So instead of sitting with the pain, we might put it back to the client and say, you know, either you have this particular diagnosis, that's unflattering, you're to this, or you're to that, or you're not being truthful, or anything. But that judgment back towards the client is really our way. Even as I'm doing this, I'm doing this with my hand. It's our way of saying, I cannot handle this, and I'm putting it back on you. So those are the three that I was thinking of. Dr. Brown added humor. I wonder if any other panelists would add any other defenses that you use, even being unaware of it.
I think going back to the denial, sometimes the denial comes up in terms of, I've been trained to do this. I should know how, I should be able to do this. All of my training says I should just be able to sit here in it. I've got this. And so I think, you know, that, especially when I was newer to trauma work, it was hard for me to sit with that feeling of, even if you have training, you can never really know, right? And so I think that the denial is the one for me.
Mm-hmm. Okay. I think now we are ready to go into our questions. So these are questions that we collected for us as panelists that we wanted to answer. And then we will hopefully have time after a few questions. I think we have 5 pre-planned questions here for any questions that you all might have for us as the panelists. So this question is to us as presenters. Does every counselor experience countertransference reactions? What would we say to that?
Yes, and if you don't think you do, that is also a countertransference reaction.
Absolutely. Absolutely.
Yes, agreed. That comes back to the the fact that a lot of times it's countertransference comes from something that's unresolved. So if you're saying that I don't have any countertransference reactions, you're basically saying I don't have any stuff that I'm somewhat unaware of or that's somewhat unresolved. And frankly, that then, I mean, then that's it right there. Like Dr. Foster is saying, we're all humans, and it will continuously pop up. No matter how much work we're doing, there will always be something new that pops up, or a new aspect of something that you have worked on in the past. We're just continuously evolving and changing beings. So yes, we will all have countertransference reactions.
Yeah, and Dr. E, I really wanted to kind of, basically springboard off of your comment about we as therapists being human. So when we talk about parallel processing, which is a subset, a grandchild of countertransference, if you will. Parallel processing is basically when we are going through something that is incredibly similar to what our clients are going through. For instance, if we've been through a loss and we're seeing a client for grief counseling, there is so many opportunities for us to co-process our grief and stuff with the client if we're not incredibly careful. And in some cases, I would argue that actually referring out if you have unprocessed grief and you're seeing a client predominantly for grief may be the most efficacious thing to do, because we're very real people, and I think it's been incredibly prevalent, more so than I've ever seen it or noticed it in my career. Through the time that we've been through in the last few years with all things COVID and everything else that we've been through as a society. Why? Because we've all been through it. We've all been impacted in very direct and indirect ways by what's happened in our society over the last 3 years. And so when we're sitting with a client who's been through something incredibly familiar and similar, it's very easy for us to get into that countertransference role because of the parallel processing piece.
Mm-hmm.
And I also like to think, Dr. E, that we're wounded healers. I think that we've either seen injustices, had injustices done to us, or perpetrated injustices in our life. And so I think that where you are with all of that really impacts the ability to be with clients in their moments of healing, pain, trauma. And so I think it's a conscious, cycle for me. I know it is for you guys, because we talk about this, to kind of sit in this idea that countertransference is an expectation rather than an exception, and being able to have people to process it with on the regular. We live in separate states up until, I guess, well, we only see each other in person on the rare occasion. However, we routinely consult with each other and say, you're never going to believe the kind of reaction that came up for me when I was seeing this person. And Dr. E will say, tell me about that. Or Dr. Brown will say, tell me about that. Or some of the other panelists who can't be here. And so we treat it like it's a very normal part of the work that we do, because if we don't, then we get into that place where parallel processing is very likely.
Mm-hmm. And Dr. Clark, I see your comment in the chat, and just resonating that's always something that we're responsible for doing, is monitoring our own wounds. It's part of being an ethical counselor at any level of our training.
So let's move to question 2, Dr. E.
Okay, what do you do when you have a countertransference reaction? Now that we've established that we all have them, so what do we do? Dr. Foster, you were sort of alluding to this just now, like you call your colleagues, you call your supervisor, you consult, you don't stay quiet about it.
I'll jump in and I'll tell them myself. I don't mind doing that. And I think I'd been in the field for maybe 6 or 7 years. And at that point, I thought I had it all figured out. We were encouraged to go through our own personal therapy in my program. And it's something I encourage for all students. And I felt like I had a good grasp on, my bag of stuff, which I think is incredibly important as you're talking about countertransference, not to be perfect. It's not about being perfect. As Dr. Foster was saying, and as what's been echoed, we're wounded healers, of course. But then there are some things that may be deeper than what we notice, I think, and that can be brought out. And after being in the field for 6 or 7 years, and of course I share this with permission, but I was sitting with a slightly older couple who were having some sexual issues and whatnot. And whenever they would come up on my docket, I would just, like, my joy would be sucked out of the window, right? I was like, I would celebrate when they would cancel or postpone or reschedule. I didn't know what it was. I was just like, I just don't want to sit with this couple. I just there's this icky kind of feeling. And finally, there was one week where I actually rescheduled them myself, and I was like, I got to dig this out. So I actually called one of my colleagues and talked with her on 2 occasions. And what I really kind of identified is this couple reminded me of my parents. And we were talking about sex and a lot of sexual explicit things with this couple. And I had really not kind of identified the fact that, this couple reminded me of my parents. And, for me, it's like, I don't really want to talk to my parents about sex, about their sex. I mean, glad they're having it and all the things and whatever, but that was not, my childhood. We didn't, that was not, something that we did. And so it was something that was uncomfortable, it was unfamiliar, and it elicited this, kind of silencing effect, if you will, with the client. But that was something I actually had to dig out through some peer supervision.
That's a great example, Dr. Brown. So peer supervision, taking a pause, saying, I know there's something here. I don't know what it is. Let me dig it out with somebody.
The other thing that I've done is really begun to recognize, like Dr. Brown said, some of my slides. For instance, with something you said really resonated with me. If you have a client that you're over eager to see or under eager to see, like, what is going on with that? And so when those kinds of things happen with me, that's definitely a slide, and it's something I have to check in with myself about and go, Susan, what is going on here?
Mm-hmm.
So I think that's the other part, is recognizing it and then getting some support around it. Dr. E.
Mm-hmm. Yeah, I'm just going to echo what you both said. Knowing, I think recognizing it, the more work you do on yourself, therapy included, and I echo what both Dr. Brown and Dr. Foster said, every counselor should be either in counseling or have done their own counseling, or maybe kind of having chapters of counseling throughout your life. When you start to know what your wounds are, what those are, you can be a little bit, not that you can prevent the countertransference, but you can be a little bit more ready to say, like, oh yeah, I really can't wait to see this client, and I'm willing to schedule them on a late Saturday afternoon. Maybe that's telling me something. Let me check my stuff. Oh yeah, there it is. And it's just a much quicker connection than if we haven't done our stuff yet. So yes, I would echo what everybody said. Peer supervision, consultation, therapy, having supportive people in your life just as friends to make sure that you are balancing your life, and life is not all about your clients. That's sometimes hard for us to do.
There's a question in the chat. Michael asks, is it ever effective to share your countertransference reactions with your client?
Great question.
Y'all definitely would, right? We know that. I have rules around self-disclosure. And this is part of my work around countertransference. I do not self-disclose unless there's no other skill to be used. And so for me, it's a no, because I want to be cautious not to put my stuff off on my client. But I'd love to hear what you have to say, Dr. E, Dr. Brown.
Mm-hmm.
Sure. That's something that I think you have to be incredibly judicious with. And, for me, my rule of thumb is this going to positively impact the client and help the client situation, or is this about my stuff? And usually it's very obvious, like I can say, this is more of me wanting to share something and get something, off my chest or what have you, but it's not really for the client. So a majority of the time, I don't. However, I will say one of the things that got me, I think earlier in my career, I was pretty much like zero, like the disclosure with my clients. And I think that, that was my own stuff. Working with, a therapist, and also I think and Dr. Foster brought up Irvin Yalom, really impacted my therapy. In individual therapy, very Yalom informed, and that brought me out of my shell a little bit, and to know that I can do it, but it still has to be so strategic, and it's so important to me that it's about the client and it's helping the client.
Mm-hmm. Yes, I would say very much the same. I do self-disclose, but not right away, and not until I have taken enough time to say, what do I need to say? Do I need to say anything here? What do I need to say, and why? And then the how. And how do I share this material in a way that keeps it for the client, and also in a way that then doesn't just open up the door for forever sharing and changing the therapeutic dynamic. And that's really important, especially with countertransference, is you don't want to put your client in a position to have to then take care of you, or to feel like they have to take care of you. So even if you might be going through something, like some of you in my class know I'm dealing with a family emergency, so I might share with my clients, I do have this thing going on, you need to know, because it may impact our scheduling. However, I want you to know I'm taken care of. Not, the tables don't need to turn here. Thank you for your understanding. And kind of that's it. And as this impacts you, we can talk about how it impacts you, but it's not now my therapy session. And so just making sure you have those parameters in place and stay grounded in your role as the counselor, not the fellow client or friend, or anything like that. That's just critical.
I think the other thing I would say about self-disclosure is it happens on a continuum. We self-disclose all the time without even realizing it's self-disclosure. Like, oh, how was your weekend? Oh, it was great. Glad to see you. That is a self-disclosure. To the other side of the pendulum, where it's, oh, I've experienced a similar trauma, and this is kind of what I've done. So, I mean, I think when we think about swinging the pendulum with self-disclosure, recognizing that it's on a continuum, and if you can't answer the question, is this in the best interest of my client, and the answer be yes, then you should question maybe why you're self-disclosing.
Mm-hmm. Mm-hmm. And if you're having that urge to self-disclose, recognize that and know that needs to go to my therapist or my friend or my colleague. If I'm feeling so moved to, like, I want to say this, that, for me anyway, that's usually the little voice in my gut, which is where I guess I hear my intuition from my belly, says, don't talk, don't say anything, wait. Why am I talking? Mnemonic device is very helpful in those moments, and checking that out first if you have that sudden urge to disclose.
All right.
Okay. Yeah. What's our next question? Can you prevent countertransference reactions? If so, how? Again, we've kind of started into this. I mean, we've talked about how important your own self-awareness is, knowing that you have stuff, knowing what it is. Is there anything that we've missed in this question, Dr. Foster, Dr. Brown?
Yeah, I think it's not, for me, it's not a matter of preventing countertransference. It's dealing with it in a healthy manner. That to me is more significant. It's not, you can't ever tell where it's coming from. And even if you've worked through a lot of your stuff, I'm not sure if anyone really always works through 100% of their stuff. And you also have new stuff that comes up all the time. Think of all the things that have happened over the last 3 years. And so you're not always, even the people who are incredibly self-aware and incredibly mindful, You're not always aware of all of your stuff. So to me, it's more of like, continuing to learn how to grow and to deal with it in healthy ways.
The only thing I would add is that as it relates to countertransference, I have a thought. It's not if it occurs, it's when it occurs. And so when we take the if out, I think we normalize it for, therapists, regardless of where you are, what you do, whatever the case may be, because it's definitely not an if, it's a when. And like you said, Dr. Brown, unless you live in a bubble and you suddenly become inhuman, you're subject to countertransference by virtue of experience. So it's not if, it's when.
And I would say one other piece I think that's been very helpful for me personally, in addition to everything we've said already, is reading, doing a lot of reading, especially around around trauma in general, since we're talking about trauma treatments and survivor clients. But if you think you're going to be going into working with human trafficking survivors or working with childhood abuse survivors or whatever kind of trauma you are feeling kind of pulled to, or you even get an indication from a client that they have this as part of their story, do as much reading on the topic as you can. Because when you're reading that material and you might be shocked, you might be horrified, you might be alarmed, you might have to throw it across the room. There was a time when I was reading something new that I thought could never exist and I wanted to throw up. If I had had that reaction in front of my client who was telling me that would have been damaging. But because I gave myself that chance to expose myself in a place where I could have any reaction that I was going to have, and then I could tend to that reaction and sort through it, then when that client did tell me exactly what I read that made me want to throw up before, I was able to be present, be grounded, hear the story, and keep it focused on the client. So not that you all want me to say more reading, I'm sure, but I am going to say more reading.
It's interesting. It's something that came up for me when you said that. Dr. E and I routinely present together on trafficking. And a couple of years ago, we were putting together a presentation and it was on power and privilege and how that and the traction that power and privilege have in maintaining trafficking. And now we've both done this work for years, right? And so you wouldn't think, or that's my countertransference talking right there, you wouldn't think that we would have a reaction. And we did. We had a simultaneous reaction as we were reading and preparing to do this presentation. We just had this idea around power and privilege. And the more we looked into it and the more we read into those who traffic and we read their narratives, we had that same reaction where we wanted to throw it across the room. And it was really kind of an illuminating experience around how much countertransference really does still exist for me around working with some of this. You remember that, Dr. E? And I'll tell you what it was. We were looking at this profile of someone who had trafficked, and we recognized that year over year, even though he's in prison, year over year, he continues to become more and more wealthy and have more and more resources and more assets, the same things that helped him be so successful as a trafficker. And it was really kind of hard to wrap your head around. And so it was just such an illuminating moment. Again, like, wow, these reactions really still exist for me. And I need to lean into this, and I need to do something with this. Because what happens if I have someone who walks in my office who has been a perpetrator? What does that look like and mean for me? They've experienced trauma and they've perpetrated trauma. What does that look like and mean? That can absolutely show up. So that just came up for me as you were talking about that.
And Dr. Foster, as you were talking about that and me remembering that and also hearing it now, and this gives us a good clue also with countertransference is I felt that in my body, even as you were just talking, like I felt that like, ugh, oh yeah, kind of a tightening, shifting, and then anger, this like protest kind of anger. So those are my first clues. If I notice that happening in my body, I'm going to notice those first before I have any kind of rational thought about what that is about and what to do with it. But I can notice and be tuned into my body so that can kind of help me say, oh, there's something that just shifted there. What was that? So being connected to your body, working with yourself and your nervous system, all of that is part of this process.
And I promise the last thing around this, something that just came up for me as you said that is that, again, we all consult with each other on a regular basis. They are so willing to call me on my stuff when I don't see it. So having people like that in your life, no, you can't prevent it, but you can have people in your life who are like, you know what, Susan, I'm going to call you on this today. I see it. Do you see it? And both of you do that for me.
There's a question in the chat. Leah asks, is there a different response depending on the type of countertransference you have? As an example, I have found myself experiencing rescuer.
Mm-hmm. That's a great question. Let me think about that.
Yeah, I would say absolutely. As Dr. E was sitting here and Dr. Foster, and they were triggering each other. Just noticing that even the way they were triggering each other, they felt it differently, but they were, triggered by the same thing. And so physiologically, what we're aware of is that trauma is held in the body. And so if you've had a previous trauma that parallels what your client's going through, you may feel that in that very specific part of your body in which your trauma is being held. It could be a gut reaction, like Dr. E was talking about, where she just wanted to physically like vomit and whatnot. And so, but I think you asked specifically about, the rescuer, that could come up in your emotions, where you're really being emotionally brought into the client's world, and you kind of want to save that person and whatnot. So I think it really depends on the situation as to how the countertransference resonates with us as individuals.
For sure. And even back to Dr. Brown, what you were saying about your couple that you weren't wanting to schedule, or you saw them on the schedule and you didn't want, like, if you're in rescuer, you might be more likely to say like, why don't we meet twice a week? Or I've got an extra 15 minutes. Why don't you stick around? Whereas if you're in maybe the victim, like I'm feeling victimized body, like, I don't want to see you at all. Nope, schedule's full this week, sorry. So it might still be around the theme of schedule, but your reactions might be different.
And then there may be, a very cognitive and cerebral response, right? Versus the emotional response where oh, I feel like I need to say something. I want to really empathize with you. I want to validate where you're at. And so I really need to self-disclose to you, which comes from a very emotional place for me, versus the schedule's full, pattern's full. And so again, as I was considering the graphic, I knew exactly where those two things lived for me on the graphic.
Mm-hmm. Mm-hmm. Yeah, great question. Okay, let's go into the next one. What to do and what is a don't when it comes to dealing with trauma-related countertransference. I'm on my trafficking wavelength. Again, we've said a lot of this. What have we missed so far? Any do's and don'ts we haven't covered?
I would just say don't try to outrun it, and do take care of it.
If you find yourself, one of the things that maybe we haven't, we've talked about, but I'll bring it out into the open, and that's avoidance. For me, in my situation, it was avoidance. Like, I'm going to reschedule the clients and whatnot. I also recognized that I have a level of stuff to deal with. And when Dr. E was sharing earlier about this book, and this book had, it gave her such a visceral reaction, and my knee jerk was, I wonder what book that is. And then I immediately followed up with myself saying, I'm not going to read that book. I don't have anything to do with that reaction. And even now, what we see with research is, 2 minutes of negative news can impact our happiness for up to 8 hours. And so even when we're talking about countertransference issues and these kinds of things, when you're treating trauma and you're given to the potential vicarious trauma and having all of those terrific details kind of brought in day after day, I find now that I reduce my amount of time listening to news, negative news, that kind of thing, almost to avoid the potential of those countertransference related issues that I don't really have to allow myself to be involved in. So, for me, it's like be keenly aware that trauma is contagious. And it's not a matter of if you're going to be impacted, it's how you're going to be impacted. And so one of my big do's is, I know we say self-care, and it can be really subtle. Like, for instance, for me, I'm careful not to see, I try not to see more than 2 trauma clients back to back anymore. When I was younger, I would see trauma, trauma, trauma. And then I would go home and I would sit in a dark corner somewhere for a while and rock back and forth. It really does have an impact on you. And now I try to, I'll have humor breaks where I'll listen to some kind of humor, tape for like 15 minutes on my drive home or after I see clients, and I'll take showers at night, even if I've had 3 during the day. It's kind of like it allows my body to know that the day is over and all of that stuff is, and just kind of washing that, off of me and what have you. And so you have to develop a really effective self-care method to work with trauma over a period of time, because it's not a matter of if but how treating trauma is going to impact you.
As you said that, I was thinking about the ritual that I have to be able to turn it off every day, and I think that we owe that to ourselves. I didn't realize how much I owed it to myself till I recognized the impact of the work I do on my family. Because, there was this standing joke that you didn't want to speak to me the first 30 minutes when I woke up in the morning, and you didn't want to speak to me the first 30 minutes when I got home. That's no joke. That was reality. And it was because, when I was very new in the field, I had a lot of trouble compartmentalizing and turning some of it off. And so really kind of sitting with and giving yourself permission to talk about how you're going to turn off the work you do will help keep some of this kind of manageable and at bay.
Mm-hmm. And with that, knowing that that's okay to turn it off, and that maybe connects to that rescuer bubble of how can I have, all of this, whatever in my life, maybe health, maybe support, maybe healthy relationships. And I'm working with clients who have none of it, who got such a raw deal in so many different ways. That sense of guilt, almost of like, I don't deserve to be happy because they've never had a chance to be happy. That's maybe that the don't neglect your own life, your own happiness, your own right to have healthy relationships, to do things for fun that have nothing to do with taking care of a client. We can really get into a self-sacrificial role with trauma clients, and that will they will not do us good, and ultimately won't do our clients any good.
Let's hop to the last question, Dr. E.
So what has been the strongest countertransference reaction you have had when working with a trauma survivor, and how did you handle it? And notice I didn't say, or we didn't say, how did you handle it effectively? Maybe you didn't handle it effectively. I know I have my fair share of those examples.
I can say fairly early on, I was treating a mother who had been in a horrific car accident and landed like pretty much upside down in a river. And she had lost there were 3 children in the backseat, and she was able to rescue only one of them. And just the details of that, and what she had to go through, and while the children were still living after they died, the whole thing echoed in my thoughts for probably 6 months, probably after those sessions. And I saw that client for probably about a year. and and brought that out in my own therapy a little bit and whatnot. And I still have I can feel it very much, and as a kind of a knot in my stomach, and that I've channeled it. I've dealt with it in positive ways. It doesn't have like a negative impact on me or my counseling at this point. It informs me a lot more, and it really helped me at that point recognize the importance of ongoing therapy. It's something I'd read about. And again, when I go back to Irvin Yalom, who's been in therapy his entire life, it seems like, and advocates for it, I can totally see why. But for me, that was definitely the strongest countertransference reaction that I can remember having, with a client.
Mine came with a child. I was a professional school counselor before I went into partial hospitalization, private practice. And I was working with this child who I had reported to DCFS 10 times. And every time I did it, I knew that it was going to be worse on the child every time. And I had so much responsibility for the fact that I was in that, I felt the abuser role and the rescuer role simultaneously. I was like, I'm going to make this worse for her. I know that every time I have to do this, it's going to be worse for her. By law, I knew what I needed to do, and I knew that, ultimately my head, heart, everything was in the right place and taking care of her. And on the 10th time, they finally removed the child from the home. And I had such a response to that. I'm a mother. I had children about the age of this child. It was extremely strong reaction. It was interesting. I found myself overcompensating with my own children. And I had to do some work around that. Because I'm like, why am I letting him get away with not doing his homework? Like what? And it came out in sort of benign ways at home, but, around doing my own work with my supervisor, peer supervision, I recognized really how much overcompensating I was doing because I felt so helpless on the other side. And I never wanted my children to ever have even remotely similar experiences. And so it was just, I cannot say enough about my supervisor and the peer support I received to be able to work through some of that.
Mm-hmm. And I think mine was, I know for sure that mine was, I was working with an adult client who was a survivor of all kinds of different types of trauma, including trafficking. And in the beginning of our work, I felt very effective, and the client was telling me how wonderfully effective I was, which feeds into, and this is all in hindsight, it was feeding into one of my wounds, which is, am I good enough? One of those very root, am I okay? Am I good enough? Do I know what I'm doing? Imposter syndrome kind of stuff that we all have to some degree, or most of us have to some degree. So that's how we started. And then quickly it took a left turn, sharp left turn. And this client was then telling me how much I was harming them and that they were going to report me to the board. And think about for someone who's like, am I good enough? Am I okay, to get that accusation of I'm going to report you to the board when you've been trying so hard to be helpful was devastating. And Dr. Foster is smiling because I was calling her for consultation through all of this. And I got to the point where I thought about leaving the field. Truly, I thought maybe I'm terrible at this. Maybe it's just been luck so far that clients have wanted to work with me and students have wanted to learn from me. I must have been found out, that imposter syndrome has come to fruition. And so I very, very seriously thought about leaving the field and kept doing consultation and did some therapy and took a step back from very high intensity trauma clients for a while, besides the one that ones that I was already working with. I wasn't taking anymore for a little while. And since then, I've had a lot of resolution around that and have found new avenues actually to continue my training in those kind of the particular collection of trauma experiences that client had, so that I can feel more equipped. And a lot of the material that we talk about in those trainings is the countertransference, is how do you deal with it when the client flips on you, because they will. And how do you understand that in the conceptualization of trauma, not in now I hate this client. And those were certainly reactions that were coming up. I was really angry. I was very hurt, had a lot of negative reactions to the client that I was feeling to the client, not that I was sharing with the client. But it was a doozy. It really was. And that will stick with me forever. And at this point, I'm trying to use that to inform my continued work for good and not to leave the field, because one client really took me down the spiral. So anyway, that was thank you, Kevin. I'm glad I didn't leave. I am glad that I didn't leave. So, and hopefully, and maybe that's where this kind of presentation was born from, is really wanting to let others at every level of training know, like, this is real and it's going to happen to all of us. And when we isolate, or when we put it on ourselves of shame on me, this shouldn't have happened, or I shouldn't have had this reaction, that's not going to do anybody any good. It's our responsibility to acknowledge it, to own it, to work on it, and to move through it, not avoid it.
So we have about Jordan, about 5 or so minutes in case anyone has any questions of us. Feel free to pop it in the chat. Jordan can read it, or come off mute and ask a question or give us a comment.
So it's not a question, but I was kind of giggling to myself. My first brush with child abuse happened a few weeks ago. And it didn't even occur to me at the time, but I definitely gave my own children like ice cream for dinner that night. And like they stayed up late playing at the park, even though there was school this morning. And just as you were talking about that, I was like, oh, that's what that was.
The big light bulb moment, right?
Right. And I was like, oh, that's why I was totally like completely spoiling them. I'm sure homework didn't get done. Like, and you know, my kids have a fabulous life. I want their lives, kind of thing. So that was interesting. Thank you.
Jordan, did we cover all the questions in the chat?
Yes, you did.
Well, thank you all for the questions throughout the presentation and for being here, and hope that this was a useful way to spend your time this morning. And I apologize again for not being able to get in here on time, but I'm glad I could join y'all.
Yes, we really appreciate it. And I echo Kevin's sentiments.